Good evening, everyone. Welcome to the another episode of Endocrine Talk Show, where we explore cutting-edge topics in the endocrinology. Over the past 18 episodes, we have journeyed together to the complexity of endocrine health, and today we dive into the other interesting topic that is the diabetes management with a focus on the fixed dose combination in the management of diabetes. Without further delay, let me welcome our course director who brings a wealth of expertise and insight into our discussion, Dr. Subhankar Chaudhary, sir. He's a director of Department of Diabetes and Endocrinology at Medica Super Speciality Hospital, Kolkata. And he's also a former head for Department of Endocrinology, SSKM Hospital, Kolkata. So without further delay, I hand over the podium to Dr. Chaudhary, sir, and request him to introduce our panelists for today's program. Over to you, sir.
Yeah, thank you very much, and a warm welcome to all our participants this evening. It's a wonderful opportunity to discuss endocrinology with you all over several months, dragging over years actually. And we always have tried to put in topics that not only have a scientific interest but also practical interest. And this evening's discussion area is no exception. In fact, we in India have a love hate relationship with fixed dose combinations. Not so long back, maybe I think it was 2016, that the government of India, in its wisdom, decided to ban more than 300 fixed dose combinations in our country. And of course, there were, through court rulings, some of those combinations have again come back into the market. Last year, once again, there were quite a few, more than 10 fixed dose combinations which were again banned. Many of them were in the nature of cough syrups and may have been prompted by what happened in some other countries where cough syrups have gone from our country, and there were deaths of several children. But we shall talk this evening about fixed dose combinations in the realm of diabetes. And again, in this area, I think we bring more expertise than anyone else in the world. And there are countries in the world, for example, our neighbor, Sri Lanka, which I feel doesn't allow any fixed dose combinations. And then there is the United Kingdom, which has no fixed dose combinations, whatever in any area of medicine. So to take this issue forward, to understand the place of fixed dose combinations in diabetes management, this evening, as in previous evenings, I am so happy to have three very dynamic people as panelists. So to introduce them, first, let's introduce Dr. Rajeshwari Janakiraman, who is Senior Consultant in Endocrinology at Manipal Hospital at Yeshwantpur in Bangalore. She is also Consultant Endocrinologist at Columbia Asia Referral Hospital in Bangalore. She has been a visiting endocrinologist for pediatric endocrinology at the Hospital for Sick Children in Toronto, Canada in 2008, and she has widely contributed to various textbooks of medicine and endocrinology and diabetes in our country. We also are joined by Dr. Arun Menon, who was a consultant endocrinologist in the UK. Then he came over and eventually was a professor in the Department of Endocrinology at the Amrita Institute of Medical Sciences in Kochi, from where he has now shifted to the Lisi Hospital in Kochi as a senior consultant endocrinologist. He has several publications in Indian and international journals. And the third panelist this evening is Dr. Shaim Siddha Mangaraj, who is Associate Professor in the Department of Endocrinology at the IMS, the Institute of Medical Sciences, and SAM Hospital in Bhubaneswar. He has been an invited speaker for various regional and national conferences, and he has an excellent academic record to his name. So, welcome all of you to this evening's discussion on fixed dose combinations in diabetes. So, can I have a quick word from all our panelists, one at a time? Maybe first I can see Arun, I can see Swayam, can't see Dr. Rajeshwari. I hope she's around. Maybe we start with Arun. So, do you use fixed dose combinations in your practice?
Good evening, sir. Good evening,
Yeah,
sir,
good
and
evening.
good evening, everyone. Thank you so much for having me in this panel discussion. I think a very, very important discussion, which perhaps is something which we do discuss in many of our private meetings and other things, but to have a lot more of national discussions, I think this is a very important topic. I do personally use quite a lot of fixed drug combinations. I'm a great fan of it.
Okay.
However, I very much know that there are a lot of things to discuss in and around it, especially some of the rational uses that has happened in our country to start with and world over, but the regulatory authorities and how a lot of these have to be looked at. I hope in the next hour or so we can discuss and go through all those points. Thank you.
Shaim, so where did you train for your?
Good evening, sir, and good evening, seniors and dear colleagues who have joined us over here for today. At the outset, I would like to thank you for having me over here for the panel discussion. So I had my training at SC Medical College, Cuttack. So I think
for
you
your
are
GM.
almost a senior, a senior faculty teacher to us.
So
I think what Saraj asked is, I do also quite frequently use fixed dose combination in my clinical practice. There are issues which are pertinent and should be discussed in clinical forums, because many of these sometimes defy logic and scientific rigor, but they are available in market. They are widely prescribed, but perhaps many of these do lack the science that should back it. So I think, but having said that, we are the only country we have so many drugs, so many FDCs approved and available to us to use in market. So I think that is one of the factors why they are so popular in the market.
Right. So do we have Dr. Rajeshwari on board? I had seen her, can't see her anymore. If not, we shall wait for her to join.
Yes, she's here.
Yeah, okay, she's there. Okay, fine. Hi, good evening. Maybe we come back to her. So can I ask Dr. Arun? So one of the issues, of course, across the globe, more so in our country, is inability to achieve guideline recommended A1C goals in many of our people with type 2 diabetes. So what are the possible impediments which could be responsible, and thereby are there ways that we could improve upon it?
Yes, sir. So there are pretty much there are quite a few areas to cover here, but the two most important bits I would think are, one, the compliance. Compliance to medications is a problem world over, and that is something which has really been an issue, not just in the area of diabetes, but any chronic disease management for that matter. And the biggest issue that we all face is the compliance to medications. And many times we would continue to increase the medications and then realize that they're not even taking it. And then, and there have been studies from, especially I can remember some of the studies from UK, where they have very clearly shown, because it's much easier in insurance-based systems where people, whether they're collecting those medicines, and they have shown clearly that you prescribe it, but they don't even collect the medicine. So whereas in our this thing, we don't know. We are giving the prescription. We are hoping that the patient will buy it, and patient will say that, yeah, I've bought it. and then sometimes the relatives come back and say, no, she has a drawer full of medications from the last couple of years. So compliance has always been an issue, and that is one thing that we all are aware of. And the second biggest thing to me is the clinical inertia that we all face in terms of adding medications. And this is many times, even in the dialogue with the patient, this comes as a point. For example, say our patient is on metformin, and we say, so yeah, you're on metformin, good drug, but we think you need another medication. They say, no, doctor, I'll get my lifestyle right. I'll do this, I'll do that. Please don't add one more tablet. I'm already having so many tablets, sick of tablets. And these are definitely issues. So then we'll say, okay, let me try. Let's wait till next time. So you shift that aggressiveness in terms of controlling sugars. And these two, to me, there are quite a few other points, but to me, these two are perhaps the most important points when it comes to managing chronic disease with particular reference to diabetes and the practice that we have.
Right. So you split that very beautifully into patient related, which is compliance. The other is physician related. Us, we are also to blame to a certain extent. And I think to add to that, maybe in defense of the patients, they often are not bothered because quite often it's a relatively asymptomatic disease. And so why bother? I mean, I'm doing okay. Yeah. So, and in this context, I do understand maybe fixed dose combinations have some role to play. And of course, another is the cost of treatment, which is an additional factor for the patients. Right. So if we turn to Dr. Shamsiddha, so we in our country, we know we have got so many fixed dose combinations, and now we are not talking of the irrational fixed dose combinations that the government has banned. We're talking of which we feel most of those are rational fixed dose combinations for the treatment of diabetes. So the Western world, quite often, I mean, there have been many write-ups in prestigious journals that India is a lost case, and there are so many irrational combinations, pharmacies overloaded. So what are your comments? Do you think it's to our benefit or it's to our harm, the FDCs?
I think if we talk about rational combinations, it would be majority of them would qualify for benefit, because as a large country as ours, with the healthcare infrastructure which we have at our disposal, perhaps FDCs have done a lot of job in a good way in at least improving the adherence and compliance to medications. So the drugs actually works well synergistically, both in terms of giving optimal glycemic control to the patient, and we have quite of those in FDCs available to us. So I think in that area they have done the job well. But while choosing a particular FDC, we'd like to definitely see whether the patient requires both of the drug concurrently to start with, to achieve the desired target which you are looking for in terms of glycemic control. Are there any problem with each of these either component with regards to any contraindications, any specific adverse event? Because in that scenario, perhaps the FDC, though might be optimal for glycemic control, may not be suitably prescribed to our patients. More so, however, in a patient with diabetes, especially when the diabetes is more than a decade or so old, when the comorbidity sets in, when the complication sets in, then we have to be very judicious while prescribing each FDC, because each component may have a different subset of acceptance with regards to in which complication this drug is suited well and where it should be avoided.
Right. So if I've understood you correctly, you do feel that FDCs are serving an important a role in our overall management of diabetes, but you've also pointed out the special considerations. We cannot use them indiscriminately. So I saw once again Dr. Rajeshwari for a brief period, but now she's gone. So we continue our dialogue, and let's get back to Dr. Arun once again. And so one of the maybe the reasons why, if not fixed dose combination, that these combination medicines are thought to be better, partly stemming out of certain trials. And one that stands out in recent times is the Verify study, which looked at vildagliptin and metformin together rather than sequential, as we quite often do. First start with metformin and then add another agent. It suggested that this starting with the combination is better in terms of better A1C achievement, less need for insulin in the next few years. So what do you feel? So do you routinely do that? For example, in people with A1Cs as low as 6.5, would you straight away start with fixed dose combination, dual drug combination?
Okay, that's a very important question. Now, I think we have quite a lot of medications now that is available. Whereas previously we had combinations of metformin and glimepiride or sulfonylureas, which would obviously cause problems in terms of hypoglycemia, weight gain, and those sort of things. And mind you, these combinations are there all over the world. Even in the US, there are combinations of metformin and sulfonylureas. But the reason why we could not start this upfront was these concerns, the hypos and the weight gain, and whether really there is any benefit by driving down the HbA1c, because our treatment was glucose-centric, was HbA1c-centric. And we all know that we have shifted our goalpost, quite rightly so, with very good evidence, to cardiovascular risk reduction and renal disease risk reduction. And that has been our main focus. Now, once we start to change that is when the HbA1c becomes less important, because the combination of medicines that we have, or the number of medications we have now, which have got beneficial effects on reducing the risk, is what has made us become more aggressive. So the direct answer to your question is, yes, 6.5, I would usually start on metformin. But if it's a patient who has high risk, a high increased cardiovascular risk, cardiometabolic risk being higher, I would certainly look at starting this patient on a combination of metformin plus SGLT2 inhibitors, because that is where the risk reduction currently remains. We, of course, know the Verify study results, which did show more in terms of not only, so that was really in terms of improving the efficacy and keeping that going. The fact that you would have, you would have a better control for more years is where Verify showed. But I think the focus now has changed to cardiovascular disease risk reduction, and our aim should be really looking at starting it as early as possible in those sort of patients, not in everyone, but at least in those patients who are at high risk.
Right. So we've got a clear view from Dr. Arun Menon. Dr. Rajeshwari, are you there with us? Okay. Maybe the connection is a little bit of problem. I can't hear you so well though. Oh, maybe.
Hello, can you hear me?
Now it's much better. Yeah. Very good evening. Welcome to this show.
Good evening, sir.
And maybe there is a little bit of extraneous noise there. Yeah. So
yeah, tell me.
So we still feel, while recognizing that organ protection is an important sort of aspect of treatment, can we get back to the others? Like Dr. Rajeshwari, maybe after the ambient noise is less, we'll come back to you, Dr. Rajeshwari. Okay?
Sure, sir.
Please mute yourself now. Yeah. So we still do think that glucose control has an important role. In fact, early control of glucose is also important. So many studies have shown. So I'll come back to Dr. Shyam Siddhar Mangaraj. So someone coming to you with an A1C 8.5, 9, or even higher. So there can be two strategies. One is to use insulin and oral agents, or to use a triple drug combination. Clearly, just a single or two drug combination, most of the time, in fact, 99% of the time, will not do the job. So, what would be your take or your approach in these cases? Do you start with insulin straight away, or do you try triple drug and then go on to insulin if needed?
So there is a very pertinent clinical question which we often face in while seeing our patients. So as sir has rightly pointed out, majority of the global guidelines do endorse going straight away to a combination therapy if you're starting A1Cs, let's say more than 8 or 8.5%. Once the patient has any symptoms of insulinopenia and the blood glucose remains very, very high, A1C of more than 9, and I see enough good reasons to start insulin, I will start with insulin, maybe add a metformin with that initially to bring down the blood glucose level, then switch over to other oral antidiabetic agents. In scenarios when the insulin need is not essential, then perhaps what I do in routine clinical practice is start a fixed dose combination of at least two drugs. Among them, DP4 inhibitor and metformin works quite well. If you give time to that, the drug is going to bring down the blood glucose quite well within the period of 4 to 6 weeks, rather than going on adding a sulfonylurea or a third or fourth line agent. I usually do not start with a triple drug to start with, but in very, very rare scenarios, like when we have an obese individual, young adult with no comorbidities, I would try to optimize blood glucose control, try also get him some degree of weight loss. Then perhaps I may think of adding a gliflozin to the combination of DP4 inhibitor and metformin. I think that would be my first choice of going in the first case. Then to further reduce maybe a patient already on existing drug, to reduce the pill burden, improve the compliance, reduce the cost of therapy, then perhaps 3-drug FDC would be the prudent choice.
Okay, so we again invite all our participants to put in your questions in the chat box. So your questions are much more important this evening rather than my questions to the panelists. And so we have Dr. Patil coming up with a question for Arun. You pitched in for early use of SGLT2 inhibitors. So the question is, can we consider SGLT2 based inhibitors, SGLT2 based FDCs from beginning in T2DM patients with low severe risk? Your views?
You certainly can consider, absolutely no problem. So because we know that the SGLT2 inhibitors have got multiple benefits, and that has been very well proven. Now, you may not be in a hurry to start that in patient whom you deem as very low risk. However, we do know that SGLT2 has got significant benefit in terms of cardiovascular protection, whether that be reducing MACE, reducing cardiovascular mortality in case of empagliflozin. So there's been enough studies to show that they are very, very good drugs in terms of protection, cardiovascular risk reduction. And as Asians, because we are dealing with a group of patients who are already at high risk of cardiovascular disease, whether they have diabetes or not. So diabetes is an addition, because we all have so many patients with pre-diabetes and significantly higher cardiovascular risk. And sometimes we ourselves know that some of these cardiovascular risk calculators underestimate or undervalue the real risk that our patients have. So if you are in doubt in terms of you think that this patient is in risk because of the multiple factors, I would certainly have a low threshold for going for a combination very early on. There's absolutely no problem with that. But I would put it the other way around. If it's a high-risk patient, certainly please don't wait with metformin thinking that, oh, okay, maybe when the HbA1c goes up, I will change from metformin to SGLT2. So I would actually put the question, just turn it around a bit more and say, in a high-risk patient, definitely go for a combination of metformin plus SGLT2. In a low-risk patient, it is certainly still an option because it will give you all these benefits, but perhaps have that discussion with the patient. I wouldn't say standard you have to start it, but still that question is still out of the way.
Okay. So yeah, so you have and we have a lot of evidence to use the SGLT2 inhibitors relatively early on in the course of the disease. Of course, if you have established cardiovascular disease or with significantly high risk, then it's absolute yes. Otherwise, also it's a good option to consider. So, Dr. Shyam, this is Dr. Manoj who asks you, do you see benefits of using FDC containing triple OADs? I prefer two drug FDC twice a day instead of using triple drug FDC once a day.
Means I think he wanted to ask whether to go for a triple drug, FDC containing triple drug once a day, vis-a-vis FDC containing two drugs.
Yes. Here, I think, yes. Please, your views.
Okay. I think that also depends upon which the doses of combination FDCs the patient is currently on. You look at the glycemic burden of the patient and what comorbidities the patient has. I think if you take everything into account, then you may suitably prescribe a triple drug. FDC may not be the answer to that. You need to add drugs which have to improve your complications, especially like what has already been discussed: atherosclerotic cardiovascular disease, chronic kidney disease, or even heart failure risk. So adding a drug which may not be a part of the FDC, that has to be added. Then you have to give a drug which is going to bring down your blood glucose, because that is the primary aim of improving the glycemic control. So I think that has to be individualized. We cannot give a blanket statement that perhaps it can be replicated and switched over to a drug containing three drugs, and that would work equally well vis-a-vis giving a FDC which contain two drugs in combination.
Right. Can we try Dr. Rajeshwari and see if she unmutes, whether there's still a lot of ambient noise? Dr. Rajeshwari, can we try once again?
Maybe... Sir, can you hear me? Can you hear me now?
Yeah, we can hear you, but there's a lot of ambient noise. Maybe the others may not. Yeah. Okay.
Yeah.
Okay, quick. Okay, let's.
Can you hear me?
Try. Yeah. So,
yeah.
What do you think are the merits or demerits of a DPP4 SGLT2 inhibitor FDC? There are a number of these available today to us.
Yeah, correct.
DPP4 SGLT2 inhibitor FDC.
Right. See, one thing, good thing about that is both have some similar profile, like no hypoglycemia and not a lot of dose variations that you require. Many of these DPP4 and SGLT2. So that combination would work. That way, the safety is there. One thing, and we metformin. We usually will start off. SGLT2 has benefit, cardiovascular and renal benefit. So despite metformin and SGLT2, if the patient requires still further something, then safer option will be a DPP4 with SGLT2. That
voice is trailing. Yeah. Yeah, Dr. Rajeshwari, unfortunately,
for most of the patients.
Yeah.
Cardiovascular wise, it is cardiovascular safe.
Yeah. So combining the two gives us more power in getting the A1Cs down, and without the additives of hypoglycemia, and also you throw in the benefits of the SGLT2 inhibitor, which we have heard being mentioned a number of times, organ cardiorenal protection. Right, great.
Yeah.
So we have another question, Dr. Manoj, this time once more, and who would take Arun? So glycemic variability is a concern in once a day FTC, in my opinion. If so he continued. Even most of us use even DPP4 inhibitor twice. I mean, this depends, of course, which DPP4 inhibitor. Yes, Arun, would you like to address this about glycemic variability?
Okay, so the glycemic variability, I think a very important question, Dr. Manoj. I wouldn't necessarily say glycemic variability is a huge problem with the combination. If you're talking about vildagliptin, yes, because vildagliptin is perhaps an agent that should be used as a BD dosing. Although we do have a 100 milligram once a day, there is always that concern because all the studies with vildagliptin has always been on BD dosing. And that concern that you have raised could come into force. Whereas you take the case of linagliptin or sitagliptin, which are the other two major agents that we use, I think that concern is much less. So really, anyway, you're not going to look at using sitagliptin BD or because sitagliptin is an agent, 100 milligram, it's once a day. That's how the dosing is. And linagliptin as well, it's 5 milligram once a day. So I don't think that concern would be there. So with Vilda, yes. With Sita and Lina, no, I don't have a personal concern. My concern with the triple agent more would be in terms of underusing the metformin dose, which could be a benefit or a risk. Benefit in terms of less of side effects of metformin because you're only using 1 gram, because all these combinations have 1 gram of or 500 milligram or 1 gram. So you see a lot of patients who have not been really well challenged with the right dose of metformin. So they're just on 500 milligram and they get all these agents added and they never go beyond that 500 milligram of metformin. So that is perhaps where my slight concern is. I mean, I wouldn't say concern, but we have a clinical issue where we have started one tablet, we have got everything. We said, okay, that's fine. But this they are already on triple agents, but not a decent dose of metformin. So again, here there is a benefit as well as a risk. Benefit in terms of less side effects of metformin, which we know increases when it's more than 1 gram, and negative thing being that we are perhaps not giving the right dose of metformin that these patients would benefit from. Because again, we know for benefit the best doses of metformin are upwards of 1 gram, 1.52. So I think that is where I would consider. And then I would also like to add that triple agents, in my hands at least, I mean, again, this is just anecdotal, obviously, and I would like to hear other specialists or other experienced endocrinologists' opinion as well. I have had wonderful results with this in terms of compliance. Many of my patients have done very well in this. But if you say my patient would prefer a combination of a DPP-4 plus metformin in the morning versus and a SGLT2 plus metformin in the evening or the other way around, that is still a very good combination because you have added everything. So, but I don't think in terms of glycemic variability, we should be doing that. I don't think there are any studies to say that because these are all once a day agents. So you take DPP-4, it is a once a day agent. You take SGLT2 inhibitors, it is a once a day agent. So if you take Vilda away, I think there is really nothing to say that glycemic variability would be more with these combinations.
Yeah, and of course, as far as once a day SGLT2 inhibitor, yes, I mean, internationally, it's only once a day, but of course, in our country, we still have some rimogliflozin usage, which is twice a day.
Yeah.
But coming to and thank you for a very balanced look and response to this question. But can I also ask you, what about the evidence for improving glycemic variability with the SGLT2 inhibitors?
So with the glycemic variability, so when it comes to SGLT2 inhibitors, we know that their benefit is on FBS and PPBS. So by the agent per se is not going to help you achieve that glycemic variability. It would be a combination, whereas with DPP-4 inhibitors, there is certainly a much better effect in terms of the PPBS reduction or the so because we are talking about glycemic variability where most patients would have a fasting which is well controlled and their PPBS starts to swing and go all over the place. So if you're looking at an overall reduction, both FBS and PPBS, certainly that is addressed to a large extent by by SGLT2 inhibitors. And then adding a DPP-4 inhibitor reduces that PPBS and reduces the glycemic variability.
Right. I mean, though the initial SGLT2 inhibitor studies suggested that they do not favorably influence glycemic variability, I think some of the later studies, including with dapagliflozin, have shown they also benefit in this regard. So can I come back to Shyam Siddha? So when do you think it's appropriate to start or add a triple drug FDC that includes metformin, DPP4, and SGLT2 inhibitor?
I think we had already discussed something about that particular combination. So it may not be a prudent choice to start with when one is initially diagnosed with diabetes mellitus, perhaps right away just giving all of what you have, looking at the blood glucose values. But once the patient is put on a combination, ideally, which could be SGLT2 inhibitor, metformin, or a DP4 inhibitor, metformin, you are looking further to reduce the glycemic burden, then perhaps adding a third line agent would suffice in majority of the patients. Then you look at improving cardiorenal outcomes where perhaps SGLT2 inhibitors remains a foundational therapy. So what I would do in my practice is when I want to reduce the pill burden, the patient is already on each of these drugs. So I can give a FDC which is available containing all these drugs, especially what Dr. Arun has also said, metformin remains underutilized in every FDC. So if you just go on adding a FDC, you look at the metformin dose, it still remains suboptimally used. So then perhaps transitioning, I would switch over to a FDC containing 3 drugs. Once they are exposed to all, having a good glycemic control, no problem with regards to any drug withdrawal, I don't want to withdraw any of these agents, then I can switch over my patient to a triple drug, triple FDC.
Right. Can I come back to Dr. Arun? So do you believe that if you add a DPP4 to an SGLT2 inhibitor, fixed dose combination or otherwise, does it reduce the risk of genital mycotic infections? There are a number of studies to support it. Do you believe that? Do you see that in your practice?
I don't think I have seen. I mean, I know about this, and there have been studies that have shown this. I don't want to overplay this, but perhaps it is what should I say? It's a benefit that we might get if we combine it. But that should not be the reason for combining it. What I'm trying to say is, so suppose your patient is getting more serious infections in terms of urinary tract infection or anything of that sort. I wouldn't want to use SGLT2 inhibitor again because I am more uncomfortable in that side. If it is just genital infections, which is mild, perhaps it's worth a try. I haven't actually seen any, clear-cut clinical benefits where people had genital infection and when I use a combination that has gone away. I haven't seen it like that. But there are studies to say that already the infection rates are less and this could be reduced by this combination. And there are also various theories why that happens. However, at this point, I would say it is something which is interesting. I would certainly, that would not be the only reason for which I would use, but if there is a patient who is having genital infection, if it is mild, I would certainly not, I would certainly not mind trying that combination. But if they're having more serious infections like urinary tract infections, I certainly wouldn't try that because SGLT2 can be tricky in those sort of situations.
Yeah, I suppose others are also on the same board, on the same page. So, Dr. Shyam, so this is Dr. Prithvi who wants to know up to what eGFR would you like to continue a FDC containing metformin and SGLT2 inhibitor?
I think one of the problems with FDCs is if you have a clinical problem in which either of the component needs a dose modification or withdrawal, then the situation becomes tricky. I think if you look at the KDIGO guidelines, earlier it was a couple of decades back, it was 60 eGFR when you need to be cautious, then it was brought down to 45, now up to eGFR of 30. They endorse that metformin can perhaps be safely be used. The patient should not be deprived of the benefit that metformin is going to give. Similarly, with regards to SGLT2 inhibitors, I think that threshold remains of less than 30. We publish of Empire trial, it is further brought down to 20. So I think you continue to accrue the benefit of glycemic benefit as well as the cardiorenal improvement. Your glycemic benefits may decline once your eGFR declines below a certain threshold with regards to using SGLT2 inhibitor, but the patient will continue to get the cardiorenal improvement. I think for that particular reason, I would like to continue the SGLT2 inhibitors, despite I may need to switch to insulin or any other agent to have my glycemic control, but I would not stop the drug. So for safe, it is EGFR of 45 or up to 30. You can give the dose of metformin may be reduced, and appropriate SGLT2 inhibitors in which trials have shown they can be safely used can be continued.
Right. Dr. Arun, we come back to you. We have so many different FTCs. So we have DPP4 SGLT2, we have DPP4 SGLT2 metformin. We now have sulfonylurea SGLT2 inhibitor or sulfonylurea SGLT2 metformin combinations. So do you think, or how do you place them? Do you use them?
Oh, I haven't started using it, sir, but I think my use would be limited. I wouldn't say I wouldn't use, because there are still quite a few of my patients who are on sulfonylureas along with all the other drugs. And it might be that to reduce the pill burden, we can use it. I don't see any other advantage other than improving compliance and reducing the pill burden with that combination. But there is also the other side where we still, as a country, we still use quite a lot of our combination of sulfonylurea plus metformin. I don't think that use is going to change that quickly either, because they are the most widely used. That's the one most general practitioners are most confident with. They're obviously becoming more and more confident with use of DPP4 and SGLT2 now, but still. So when you're transitioning from a glimepiride metformin combination, which is perhaps the most commonly used combination at the moment, to adding a third agent, and you don't want to increase the pill burden, you can certainly look at a combination with sitagliptin, which is, I'm sure that is the one that's available now. I'm sure we will see the other combinations coming through in future. So certainly, I don't think my use is going to explode in that scenario. Whereas, as Madam was saying earlier, the benefit with SGLT2 and DPP4 is that their doses are fairly fixed. So you add, that's it. So whether that be 10 milligram of DAPA or 100 of Sita, that's it. You have achieved what you need to achieve. Whereas with glimepiride, then there is that issue of, okay, are you going to make it 0.5? Then many times what patient has a hypo, what the patient will do is patient will try to cut that triple drug into half. That's a trick that all our patients play all the time, isn't it? They get a doubt whether they're having a hypo, they will just break the tablet and take half of it. Now, when you start to do that, then you're reducing all the important drugs. So you probably would have reduced the glimepiride from 1 milligram to 0.5, but then you have reduced everything else as well. So this could be a tricky situation as well in a lot of our patients. So unless the patient understands that these tablets have to be taken the way we are prescribed, or if it is patients who are erratic in terms of glycemic control, as well as erratic in terms of compliance, I wouldn't want to use these sort of triple drug combinations. Whereas a triple drug combination in terms of one that doesn't cause hypos and which has very fixed doses, like the metformin, SGLT2, D4 we have been talking about, I'm much more comfortable with. The other one I might use, I'm not saying I won't use, but would be less used.
Yeah, and as you correctly said, the sulfonylureas are more or need more dose titration, whereas the others, DPP4, SGLT2 inhibitors, do not. So you need to have different strengths of these FTCs, looking basically at the sulfonylurea component, essentially maybe the glimepiride component, right? So we have actually, I mean, we will continue to have more and more different FTCs coming up. What would, Dr. Shamsudha, what would be your views of, and which is not there to the best of my knowledge in our country, combining a pioglitazone with an SGLT2 inhibitor? Sounds wonderful combination, doesn't it? Or what do you suggest? Would the pharma industry just lap on this? Why haven't they done so far?
Absolutely, sir. If you look at the prospects of the two, how they work, what they both bring to the table, perhaps the combination seems alluring. I will just like to add certain things. The last decade has been of SGLT2 inhibitors and GLP analogs. They are the molecules which have completely changed the way we perceive the disease and treat the disease. The landscape of algorithm, everything has changed after the publication of those trials. But if you just look into finer details, SGLT2 inhibitors, despite reducing the ACVD events and reducing mortality in certain scenarios with certain drugs, but the actual reduction with regards to myocardial infarction rates or stroke rates are not achieved. Perhaps these drugs do give you benefit with regards to ACVD events, but those are predominantly driven by reduction in the hospitalization for heart failure, or they merely act through the pump and the pipes. I think they improve those hemodynamic parameters that perhaps translate into improvement in the ACVD events. However, if you go a decade back and look at the trials of glitazones, especially pioglitazone, like Proactive, IRIS, or even Periscope trial, what they have shown is that in all these trials, there is significant improvement in the MACE outcomes like myocardial infarction rates, stroke rates to the tune of 15 to 20% in certain trials. Because this drug actually acts as an anti-atherosclerotic agent by multiple mechanisms, one of them being an insulin sensitizer. So I think combining these two is going to give you benefit, at least theoretically, but there are problems. Like, I do not know if the benefit which the SGLT2 gives currently, that would be jeopardized if I start them on a glitazone, whether those magnitude of benefit would be still be given by that drug. And one thing is, there are less trials addressing that. To my knowledge, there are few RC meta-analysis comparing on 4 or 5 trials, some data from the Taiwanese or Korean institution-based database from the insurance part, where they have shown that the combination works well. It brings down your event rates, improves your A1C. But a specific trial addressing this combination, whether that translates into retarding the complication rates that we are talking about, is actually lacking. But on paper, this actually looks promising.
Right. Can we try Dr. Rajeshwari once more? Can you just unmute and let's see? It's much better, isn't it? Yeah, there's not much of outside noise there. So we have discussed a lot. I'm sure you've been following the very valuable comments made by our other panelists. So we do understand the different benefits of SGLT2 inhibitors.
Can you hear me?
Yes. Could you hear us? Could you hear us? No, possibly. No, okay. So we Dr. Rajeshwari, no, maybe we have to take you on another time. We continue discussing with Dr. Arun and Dr. Sayam. Okay. Right. So we heard a lot of benefits of the FTCs. So what are the practical limitations, Dr. Arun? We have, of course, discussed some of them. So what would be your cautions about the use of FTCs?
Yeah, I think many of the problems with triple agents we have already talked about. I think one of the major things is the lack of evidence supporting their use. I mean, if you take some of the combinations like with the combination DP4 plus metformin, there is very good studies to support their use, and that gives us a reassurance that these agents work. Now, when you go into the triple drug combination, when you go into adding glimepiride onto it, you do wonder whether there could be more and more of drug interactions or less effect of one of the agents. We are not sure about this. And especially when it comes to the major reason why we are using early DPP4 is because you want to get the maximum benefit in terms of cardiovascular reduction. Now, what if somebody was to challenge us and say, how sure can you be that combining all these agents, you're probably going to negate that? Unless we have evidence to support it, you can only guess. You can say, no, I think that's going to give the benefit. But there is really no support in terms of literature. So I think that is the biggest concern when you go for this sort of combinations, whether they would reduce the real benefits in the long term that the SGLT2 we think is going to provide us. I think that's one of the major things. The second thing is what I said earlier in terms of these combinations, and there's a lot of lack of clarity with the naming, with the nomenclature, which is one of the problems I practically face in a lot of these things. So there will be many patients will come and tell you, I'm in a combination of glimepiride and metformin. And then when you actually take the tablet, they might be on a glimepiride, metformin plus pioglitazone. So either they have made the mistake or the pharmacist has made the mistake, or, so this happens quite a lot.
Yeah.
And sometimes, so many times when they are on multiple drugs, I actually tell them, you please bring the medications next time. Because otherwise, when you see the side effects, you're not sure whether, is it because she has, say she has a bit of pedal edema. How can you be sure that it's not due to pioglitazone? Or is it because of heart failure? Or is it something else going on? So there can be so many clinical scenarios which we will have to clarify in this situation. So I think that's a big problem that we have. When you combine more and more agents, you will end up with combinations which you would just write the name of a drug. You may not put, that is again one of the problems we have. So suppose a combination of a 10 milligram of the 10, 100 and 1000, a combination. Now there could be a 10, 100, 500, 10, 100, 500 combination. Now, many people may not necessarily, many doctors or physicians may not completely write this. They will just write the name of the drug. And then there is this confusion. I mean, of course, if I can just draw a corollary to this is one of the biggest problems we have had is with insulin, isn't it? The Humalog scenario, where even yesterday I had a patient who said, I'm on Humalog. So I said,
okay,
what Humalog? He said, no, I'm on Humalog. So then it's a big problem. I said, is it a Humalog Lispro or is it a mix? And she was not sure. So then I was straight away not sure how to advise her. I said, you have to bring this or send me the photograph on WhatsApp. So the problem with nomenclature is a big thing, especially in India. And there are so many kind of very fancy names. There are even drugs which, I mean, again, another corollary is there was 2 antibiotics. Somebody had written, so there is a Roxid and a Roxim, as you know. Roxid is a cephalosporin and Roxim is a roxithromycin. And this patient, the patient says the patient took Roxim and developed allergy, and this patient is admitted now. Whereas the dermatologist has come and written that it's Roxid that she had allergy to. Now you're not sure which one the patient took. Yeah. So the nomenclature becomes a big problem in India, and we have to address this because there are so many companies, so many things, and unless we start to address this, we will be confused, and our patients are the ones who get disadvantaged with this.
Right, and Dr. Rajeshwari has also added some of the triple drug interactions. Yes, so interactions will be an issue, and then, I mean, most of these anti-diabetic combinations that we have talked about, possibly drug-drug interactions, have not been a major problem. But if you have adverse effects, then you do not know which drug is causing the adverse effect. And then, of course, the risk of hypos when you add a sulfonylurea to this combination. So these were valuable observations from Dr. Rajeshwari.
Absolutely.
Dr. Shoyam, would you have anything to add to this?
No, I would just I'd like to add on a lighter note what Dr. Arun has said. I think with the off patent, the 2 major molecules going off patent, the gliflozin and DP4 inhibitor, now physicians have a dilemma in identifying which drug combination actually the dose contains. I am also very, very confused now. People are coming and promoting drugs. I myself cannot make out what actual combination that FDC contains. So you name a drug.
Sometimes they themselves are not sure. Poor reps,
we are not.
They themselves are not
so
sure.
Rest alone on patients. The physician is now in confusion and in dilemma. While prescribing what combination actually that FDC contains.
Absolutely.
Yeah.
Absolutely.
And as Dr. Arun said, I also try and insist that the patients bring in the medicines they are on. Sometimes they feel a bit let down that they show a prescription. The prescription is there. But still, I say, please, you show me what you are actually taking. That clarifies in a large number of cases. So maybe we are coming towards the end of our discussion. And we talked about 2 drug combinations. We talked about 3 drug combinations. Now, what are your views on 4-drug combinations? So you have, let's say, SGLT2 inhibitor, DPP4 inhibitor, metformin. But we are all agreed, I'm sure, that pioglitazone is also a great drug to have. Pioglitazone, if you add to this, will not increase the risk, will not cause hypoglycemias, and may add some vascular benefits. So maybe Shine first and then Arun, 4 drugs, 5-drug combinations.
I think that that combination perhaps takes away the clinical decision making from the physician altogether. You just write a drug because the patient suffers from diabetes and it will be taken care of. I am not a big fan of that. There are a lot of problems inherent to that because we cannot titrate the drug. There is a difficulty in the combination has an adverse event. Entire thing has to be taken out. So I think it should be limited to 2 or max 3. I think 4 or 5 remains a very dogmatic problem in clinical practice, and I think that should not be promoted because what usually happens in general practice, if you have a drug at your disposal, people will write that just looking at the blood glucose values, they will just write a drug which contains the maximum number of agents. That happens across the country and everybody will agree to that. So I think that should not be made available so that at least people use their clinical judgment and whatever they have read about the disease and understand the disease.
Right. And Dr. Rajeshwari echoes what we have said. And she says, clear no to 4 drugs, difficult to titrate, and to take care of the side effects. Yeah, Arun, what are your views?
I 100% agree with my co-panelists. I think it's uncharted territory. The side effects will be more. We will not realize for a long time that the patient is on 4-agent one or 5-agent one, because many times they would do is to add a M and a P and XC into this, and you wouldn't know what this is MPC or MPC D E F G H. So all the alphabets of English would be used in that. I think it is I certainly wouldn't vouch for it. I think why I like the combination of DPP4, SGLT2 and metformin is because one thing is the side effects are very less. Now, and we know the very clear-cut side effects of some of these agents. And as long as, and many times I don't even go straight for this, to be honest. I should take a step back and say that. Many times my practice would be to use the separate ones first and actually discuss with the patient and say, suppose your control is better next time, you don't have any side effects to say these agents, we can look at combining these and then reduce your pill burden. And that actually serves as a motivation for the patient. So you might use it as separate agents, make sure that these agents are not causing side effects, and then try and combine. So my practice in terms of going for a triple drug combination straight away is actually much less, because I still have this concern as to whether once they develop side effects, whether we will realize that. So I have found that better. When it comes to 4, I'm sure we can't monitor that well, and we will have more trouble. So at this point, unless we have very clear, robust evidence coming out from literature, which I think we may never get because these agents are being so much used, I don't think we are going to get good quality studies because that will be very expensive. And who will bear that money? Companies are not going to do it because these drugs are anyway marketed. The patient will have to bear that cost. And in a very competitive market, I don't think the prices can go up either. So I don't actually see any robust studies coming out in these sort of combinations, which will help us change our clinical practice. So I think I would be more cautious, stick to the triple agents for now, unless the scenario changes, and use these agents judiciously. Thank you.
Right. I think we had a wonderful discussion. So there are so what we understood is there would be 2 different clinical scenarios for the use of FDCs. One would be when the patient is already on the individual components separately and are doing well. In order to reduce the number of pills, the pill burden, you may now provide them the option of a FDC. The other could be where the A1Cs are well beyond the target, whatever you decide on, and where you are unlikely to reach that target with 1 agent. Then you may start with an FTC of 2 agents and sometimes even with a 3 agent. So these are the 2 broad groups where you would be using FTCs, and our panelists have clearly voiced, all of them. Dr. Rajeshwari, actually, I voiced whatever she wrote in the chat box because we are not able to get in touch with her easily. That we have our concerns. I mean, we want to not get the anti-diabetic FDCs get a bad name, which many other FDCs have got and have been banned from this country. So we would, for now, like to be happy with dual or triple drug FDCs, not beyond that. They do have an important role, and in the process of combining the drugs, usually the cost also comes down. So that is also an advantage. But there are issues of dose titration, especially if you have something like sulfonylurea. You have risks of hypoglycemia if you have a sulfonylurea-based FTC. And also, if you have side effects, then which one to take off. So you have to break down that FTC and bring and go on to separate agents. So all these are limitations, but the usage has increased, and that has, while it has made things easier to a certain extent, has also made it complicated to remember all the different FDCs, especially the different combinations and the different strengths also that are there. So overall, I think it was a good discussion, and this was sort of supported very well by active interest by our audience who posted important practical questions. And so with that, I would like to thank both our panelists this evening, three of the panelists actually, not both, sorry. So Dr. Rajeshwari, Dr. Arun, Dr. Sayam, thank you very much for sparing your Saturday evening with us. And of course, for all those who have joined. So Dr. Mithilesh Naik can give us the final count of how many people have joined in. So it's been a wonderful evening spent, and I hope it helps us improve our practice of diabetes in the days to come. Over to Dr. Mithilesh Naik for the final words.
Thank you, sir. So as we are about to close yet another insightful episode of Endocrine Talk Show, I want to take a moment to extend my heartfelt gratitude to all those who have made this discussion possible. So first and foremost, huge thanks to our esteemed co-director, Dr. Chaudhary, whose vision and dedication were instrumental in shaping today's session. Your tireless effort in creating topics of utmost relevance and assembling a panel of experts are truly commendable, and we are immensely grateful for your leadership. Next, I must express my deepest appreciation to our distinguished panelists, Dr. Arun, Dr. Mangraj, and Dr. Rajeshwari ma'am. Your expertise and insight have enriched us in today's session. Each of you have brought a unique perspective to the table and enhanced our understanding regarding the fixed dose combination in diabetes management. I also want to extend my gratitude to our dedicated audience. Today, we have more than 600 registrations who have joined today and attended live this program. So I thank you, each one of you, for your unwavering support and engagement. Your enthusiasm fuels our passion for knowledge sharing activity, and we are deeply grateful to getting opportunity to connect with you week after week, month after month. So until we connect next time, stay curious, stay informed, and above all, stay healthy. Thank you and good night to everyone.